I'm going to just give a little bit of our experience with endoscopic management of CSF leaks and encephaloceles, and you will hear a lot of the same things that I'm sure that you're hearing from other presenters here this afternoon, some excellent talks. So I want to discuss specifically a little bit about diagnosis and how I go about diagnosing a leak when I see a patient, and I'll discuss a little bit about etiology of leaks and their implications for me in terms of what kind of repair that I choose to do, as well as how I alter my repairs based on the location of the leak. So I think that one of the things that's really helped us tremendously in terms of identification of leaks has been the Beta2 Transferrin testing. Obviously, this is best for patients that have active or inducible type leaks, such as this one that you're seeing here on the screen. You know that Beta2 transferrin is produced in the liver, and it is found in CSF as well as the aqueous humor of the eye and perilymph. Occasionally, it'll show up in saliva, serum, and tears. It does require somewhere around a half cc to upwards of 5 cc's, depending on your testing ability. And it does remain stable at room temperature for several days, so that's good news. Most testing labs will recommend that the material be sent to the lab and be tested, though, within 4 hours. There are 2 different commercially available tests. Currently, there's an agarose gel electrophoresis test as well as an immunofixation test. Both of them are effective, and both have fairly similar sensitivity and specificity, somewhere in the 80 to 90, maybe upwards of 100% with the immunofixation type test in terms of its sensitivity. There is some positive interference with blood, and so you do have to be careful to not give a specimen that has blood. BetaTrace protein is not available in the United States. It is available in other countries. It's a prostaglandin D synthase produced by the epithelial cells in the choroid plexus. It's 35 times higher concentration in CSF than plasma. It is considered a less time-consuming test for our lab pathologists, and less fluid is necessary. And sensitivity and specificity are equivalent, fairly similar to what we see with the Beta2 testing. I don't rely on radionuclide testing with pledgets very frequently. This is a fairly common technique in some practices. Perhaps for the patient that shows up who doesn't have clear evidence of CSF rhinorrhea, it may be something useful because the patient does have to have the pledgets in place for a period of time, so it's possible with movement, ambulation over a period of an hour or 2, you may induce some CSF, and that may be able to be identified then. High-resolution CT, intrathecal contrasted CT, is obviously very helpful in those patients with obvious leaks and with encephaloceles and meningoencephaloceles. MRI can be helpful as well. But I don't want to downplay the benefit of endoscopy. Endoscopy it can be just very, very helpful. Here's an example, just a patient valsalving in the clinic from a leak in the sphenoid sinus here. And here's an example of just a small, subtle leak in the olfactory cleft on the patient's left side, just immediately adjacent there to the middle turbinate. And of course, you see a leak like this during surgery, a very small amount of flow that you can perceive with the endoscope. The endoscope is incredibly valuable to us in identifying these types of things. I really like intrathecal fluorescein. Intrathecal fluorescein is very helpful at identifying these leaks. It's not approved in the United States by the FDA for intrathecal use. However, fluorescein is very, very safe at very low doses in the intrathecal space. At higher doses, it can cause meningeal irritation and even seizures, but at low doses, really no significant complications have been reported. We use 0.1 cc's of a 10% solution and mix it in 10 cc's of the patient's own CSF and infuse it into their intrathecal space over the course of several minutes. And this we find to be very, very helpful. Patients can have this done in the clinic. They can have this infused in the clinic. They can go and walk around for a while. They can get lunch. They can come back, and we can do a nasal endoscopy. And it is very easy to identify the fluorescein in many, many cases. You do not need a blue filter to be able to identify this. Even a small amount of leak can frequently be identified with a typical xenon light source that you would have in your own clinic setting. Again, I just emphasize that there is much greater risk related to this drug when it's used at high doses, so you have to get the concentration correct. You have to use a low dose when you instill it intrathecally. Now, the etiology of the leak does change my approach a bit. We know that meningitis in traumatic leaks is probably estimated at somewhere between 6 to 9% of cases occurring within the first week. An annual risk related to a traumatic leak is thought to be somewhere between 7 and 11.9%. So the annual risk of meningitis, 7 to 12% in patients with traumatic source of leak. These are coming from data from very large head injury studies, and mostly we note that there is a much higher incidence of meningitis from CSF rhinorrhea versus CSF otorrhea, a big difference. So if a patient has a traumatic leak with rhinorrhea, that's something that we're very concerned about and we're going to be more aggressive with. Now, that being said, they do tend to respond to conservative treatment. So we know that we can put these patients on bed rest and perhaps in some cases use a lumbar drain, and they will respond well. Iatrogenic leaks, we don't know exactly the incidence of meningitis related to these, but we believe it's going to be approximate to what we see with a traumatic leak. I would argue that these leaks, once identified, should always be managed immediately with surgery. There's no role, in my opinion, to manage these patients conservatively with bed rest or with a lumbar drain. These patients need to be taken care of right away with surgery. Spontaneous leaks are definitely different. The incidence of meningitis from a spontaneous leak is definitely lower than what you see with traumatic leaks and iatrogenic leaks. So these patients are not, it's not as necessary to be as quick in taking to these patients to the operating room for management. Obviously, the risk is very much there, so we don't take it lightly, but however, it is not as an emergent case like it would be with some of our iatrogenic leaks. The location and the size of the leak is definitely going to dictate the type of repair, both with respect to the ability to access the area, as well as, frankly, just being having to counteract the effects of gravity. So here you see a nice leak that occurring in the region of the ethmoid there on the lower picture. You can easily access this area endoscopically. However, you could, and using a graft in this area, it's fairly easy to counteract the effects of gravity. You deal with a leak that's up in the frontal, it's a little bit more difficult to access that area endoscopically. You have forces of gravity that tend to want to pull your flap down, your reconstruction down. And of course, in the region of the sphenoid as well, when you're dealing with a cellar leak, the graft tends to want to pull down from the top corner. So it can be a challenge sometimes to get that graft secured and hold it in position. I do feel that it's critical to get the margins of the leak identified and completely cleared of mucosa. All right, these are fistulae in the spontaneous leak that's been present for a while. These are fistulae. They have an epithelial lining. That fistula has to be cut out, has to be burned. And I like my bipolars. I have a whole assortment of bipolars to use, and that's absolutely critical to getting the leak controlled. I don't typically, as I'm illustrating in this video, I don't typically do underlay grafting. I did in the past. I've just found it's not, frankly, necessary in the vast majority of fairly small leaks. We are using a little cartilage here as an underlay. I think just doing an overlay is really quite sufficient in the vast majority of cases. My workhorse repair is using free mucoperichondrium. I like it. I get a nice, big, healthy piece of mucosa off the floor of the nose, and it really is a beautiful piece to lay up against the area of the defect and for it to take hold. Obviously, pedicle grafts are great. They can be quite helpful, but you certainly don't need a pedicle graft in every situation. I just cover these after I place the graft. I cover it with a little bit of microfibrillar collagen, maybe some tissue glue, and that's really about it. So it's fairly straightforward. It doesn't have to be a very complicated scenario. Sphenoid cellar leaks, typically for a pituitary type repair, if there's no obvious leak, don't do any significant reconstruction of the sella. If there's a small leak, I will typically fill the area with fat, mainly to just occupy the dead space. And once again, I like my free floor graft. So I'll just get a nice healthy piece of mucosa off of the floor. We put a little fat into the sella to occupy that dead space, and then cover the area with our mucosa that we've harvested off of the septum and off of the floor. It goes on very nicely, and it heals very, very quickly. It's a very effective treatment for small, low-flow type leaks that we see in the sella. So if you're dealing with a lateral sphenoid, this is a very different situation. This is a challenging leak, I find, and I think it's really important to kind of take these carefully. Obviously, it's important you visualize the carotid artery in these leaks. I've had one case where a patient presented with a leak and was billed as just a sphenoid sinus leak that in fact had a pseudoaneurysm of their carotid occupying the entire sphenoid. It can happen, so you need to look at that carotid artery before you do any sort of reconstruction. And it has been well recognized by many surgeons, many of our friends, that these are challenging leaks. This is a report from Stamberger's group back in 2009 in rhinology. They noted that the recurrence of lateral sphenoid sinus leaks after repair for them was 40%, so very high rate of recurrence. And I think really, honestly, the big issue with these leaks is really just exposure. It's getting I said before, with my idiopathic and with my spontaneous leaks, I really want to be sure that fistula is completely exposed and completely cleared of scar and of mucosa. And it's just a challenge to do that in some of these lateral sphenoid leaks. I also point out that the commonly people thought these were related to Sternberg's canal, though that has been since disputed. Sternberg's canal occurs medial to the infraorbital and to the foramen rotundum. And as you'll note on that CT scan image on the top there, nearly all of these lateral sphenoid leaks are actually lateral to the foramen rotundum. So it's not related to Sternberg's canal, as we've previously said. So I like the transpterygoid approach for repair of these leaks. We create a hole in the back of the maxillary sinus, access the pterygoid palatine region, and we put some clips on the internal maxillary artery there, and that allows us to cut it. We get a nice big now opening with our drill directly into the sphenoid sinus. This gives us a nice 0-degree view of the meningoencephalocele right here through that defect. And now we have two ports. We can use our angled scopes looking over from the medial aspect into the sphenoid sinus, where we can use our cautery, our bipolar cautery, and a 0-degree type view through our transmaxillary type approach there. So we're using two different routes of access for these. And again, this allows us to get that nice removal of all of the mucosa to really cauterize that lesion very well. Again, in this case, we'll go ahead and put a little underlay of bone here, but I don't do that now very commonly. But we do rely, once again, on just a simple floor graft, a very nice, healthy piece of mucosa, oversized. Large defects, this is the pedicled septal flap. Anything with high flow, very large defect, we can use the pedicled septal flap. Very great advance for us in reconstruction. And more recently, we've been using an anterior ethmoid flap, which is based on the anterior ethmoid artery. And we like these very, very much. We feel they're very, very useful. We've done a couple of repairs just recently, and it's a nice, healthy flap. Again, these are typically for total hypophysectomy cases, extended pituitary cases, not really for typical reconstruction. So just to conclude, endoscopic repair has really been wonderful for us in terms of
Dear doctor,
these procedures.
your time.
It is quite effective, very low morbidity, mortality. But do think about how and where the leak is occurring. localize that leak. I love the fluorescein, intrathecal fluorescein, tremendously helpful for us, and I really do like the humble floor graft. It's not as fancy as the pedicle grafts. I get it, I understand, but boy, they really do work very, very well in a large percentage of situations. The Haddad flap, a great flap. Anterior ethmoid flaps, really interesting. They do work. Also, nice, healthy pedicled flap. So thank you very much.